Welcome everyone to another Wildcard Wednesday. It is Wednesday, March 11th, 2026. And last week, after I did Wildcard Wednesday, and I believe during Wildcard Wednesday, I asked my audience to send in some cases because I didn't have any more cases. And my audience did not disappoint. I got bombarded with a bunch of cases for Wildcard Wednesday. So today I'm going to do two that were submitted, and then next week I'll work on doing some of the other cases as well. So I will get through the cases, but obviously if I get a bunch in 1 week, I can't do them all in 1 week. But whenever I actually post a case on the channel, the person who sent me the case, I will drop them an email and let them know that it has been posted. So if I post your case in Wildcard Wednesday, you will get an email from me confirming that it is up on the YouTube channel. So if I didn't select your cases this week, stay tuned because they will be in a future episode. So let's go ahead and jump into our cases. So because I had so many, I did decide to go through two cases this week, and I picked the first two that came in. I'm taking them in the order that they came in. So case number one, we have a lower extremity intervention. And with this particular case that was sent in, I was sent not only the interventional radiology report, but I was also sent the CTA as well. So what I did is I kind of, did a copy and paste and merge the documentation together just to make it easy to follow for discussion purposes. So what I did in the beginning of the report was I inserted the findings for the CTA so we could discuss that. So this patient, we look at our history and indication, and we see that it says patient with non-healing ulcer of the right foot, referred for angiogram and possible interventions. So you know that in prior sessions, when I've talked about whether or not you're going to code diagnostic angiography, one of the things that we look for is whether or not the physician already knows that they're going to intervene and how they're going to intervene. And in this case, the report itself mentions possible intervention. So typically based on that statement, I would say, okay, we know that we're going to code the diagnostic angiography. Well, with this case, because I have the CTA findings, I would probably have a little bit of hesitation without having more documentation in this report. Now, I am going to go ahead and code the imaging on this case, but ideally what I'm looking for, if I'm putting on my auditor hat and I'm thinking this through and I'm looking at it from the payer perspective, right? And we're giving it that extra scrutiny, I see that that CTA was done 1 day before, and I look at the findings in that report, and it's severe atherosclerosis that is documented in the vessels, the AT, the PT, and the perineal, which end up getting imaged the following day, and then an intervention is performed. So in the report, further in the report, I would like to see a clear statement of medical necessity, like ideally. Now, as I said, I'm going to code the imaging. I'm going to go based on that statement of possible interventions. But if we're looking at it from the payer perspective, the payer may see this and feel that the diagnostic angiography, the catheter-based study, is not reimbursable. So that is potential. So you just want to keep that in mind there. So I would feel more comfortable if there was a statement in this report explaining why the catheter-based study was needed when that CTA was done the prior day. It could very well be that the physician needed additional details, that the imaging wasn't clear, whatever. There could be something, some specific reason why the catheter-based study had to be done prior to deciding to move forward with an intervention. So again, ideally, I would like to see that documented in the report. So with that said, let's move on. So we see that we have our documentation for sedation. Our sedation time is documented, so you can report your sedation. We're going to go down into the report details, and we see that ultrasound guidance was utilized, and we have access at that right common femoral artery. And then the catheter is moved antegrade. So that means the catheter is going down that right extremity. So enters the groin. And now we're going to go down towards the knee. And it says the tract was dilated and the sheath was placed into the right popliteal artery. And then a right lower extremity angiogram and runoff was then performed. So at this point, we have our imaging. And I said that we would assign the 75710. And then, of course, we'll need our NCCI modifier on the 75710 because we're going to code an intervention. So from that point, the catheter then goes into the right posterior tibial artery, and then an angiogram is performed of the right posterior tibial. So you'll see that I have 75774 with a question mark around it. And then if you look in the paragraph under that, I have 75774 question mark. And then further down in the report for the AT, I'm going to have the same thing. So I've seen differences of opinion on utilizing the 75774 in the lower extremities. Some will say that it shouldn't be used for a continuation of the extremity. But then if we go back and if we look at how this code is utilized in other vessels in the body, and we look at the requirements for it, then I think there is an argument potentially to be made for assigning the code. So if I'm looking at 75774, if I'm considering assigning that, what do I want to look for in my documentation for this add-on code? The first thing that I want to look for, where was the catheter for the prior angiogram? And then did the catheter move further? Was it more selective? And the answer to that question is yes. The catheter was moved to the right posterior tibial artery. So we know that the catheter was moved further down the extremity more selectively. We have criteria number one. And then the second thing that I look for is, do we have findings that we didn't have before? Are we seeing new findings? Perhaps from the first contrast injection, maybe there was not adequate visualization of the posterior tibial. Maybe there wasn't visualization for whatever potential reason, and then the catheter had to be moved into that vessel for that additional imaging. So as far as the catheter placement is concerned, we meet that. And so what I did with this case when I was reviewing it, when I saw this, I went down and I looked at the findings section to see, and I noticed that the findings section actually separated the findings for each catheter placement. We see the findings for that initial catheter placement, then we see right posterior tibial findings, right perineal, right anterior tibial. So to me, this looks like they were separate studies with separate interpretations. Now, does that mean that they were? Can we say that 100% for sure? Not necessarily. It could be the way that the report is laid out. Because if these vessels had been visualized from that initial contrast injection and findings were given, then I would not be using the add-on codes for those vessels that were visualized from that initial contrast injection. So for me, this report kind of sits in that gray area for the add-on code for the 75774. So with this, again, for illustrative purposes, I'm going to go ahead and like code it. And I told you the criteria that I'm looking for. So I feel like just for educational purposes, this is enough. Obviously, these gray areas that I talk about during any Wildcard Wednesday, these are things that you need to discuss internally and then decide how you want to move forward with coding certain scenarios. I know I work with a bunch of people from all over, and some providers are very conservative, and then other ones are kind of, middle of the road, and they will, code for things. The add-on code, though, can be a little bit tricky to get paid for, particularly multiple units of that in an extremity. So there could be an issue of assigning that code. You're probably going to get some denials and you may ultimately not get paid on it. So there are just a lot of considerations that are going to go along with that. But again, the two things that I look for: was the catheter moved more selectively? Yes. And then do we have new findings of the vessel that was imaged that we didn't see from the prior injection? So that's what I'm looking for in the report. Okay, so now let's get back to our intervention. So we see that the catheter was placed in the right posterior tibial, angiogram was performed, then a laser atherectomy was performed, and then an angioplasty balloon was also used to facilitate completion of that procedure. So in this paragraph, we don't see any type of findings. We don't know whether or not we have a straightforward lesion or a complex lesion. So I had to come down to the findings section, and you'll see I've put in bold the findings. So when we look at the findings section, it says multifocal stenosis and occlusion, and then it says that for both vessels where we had the intervention. And then in the impression, it specifically has total occlusion, which we love to see the exact language, right? Total occlusion. So these are both going to be coded as complex lesions, the ones that were treated. So I'm going to go back up here. So I assigned 37290 which is for atherectomy and angioplasty of a complex lesion. Then coming down to the right perineal, I already talked about the catheterization and imaging with the 75774. Here we also see that atherectomy was performed with that laser device and then followed by balloon angioplasty. So now we're still in the same territory. So now we have an additional complex lesion that was treated with atherectomy and angioplasty. So we're going to use add-on code 37291. Then we come down to the next paragraph where the catheter was put in the anterior tibial and imaging was performed. And then it says multiple attempts to recanalize the right anterior tibial artery through antegrade approach was unsuccessful. So the specific question that came in with this case is, can we code anything for the right anterior tibial? And because they didn't facilitate performance of the procedure. So here, and I believe the question was, can we get a catheterization code for this? I think that was part of the question, if I remember correctly. So you're not going to code actually anything for this. The only thing potentially you would code is possibly that 75774 for the imaging component that we talked about. The catheter work is bundled with the codes that have already been assigned. So you're in the same territory, and that catheter work is going to be bundled regardless. So you're not going to get catheterization of the right anterior tibial. It is bundled. We don't see that any portion of the procedure was performed. And because we have two other successful procedures, I don't see anything else here that is codable. So no, there's no catheterization code for the anterior tibial. There's no intervention, even with a modifier for the anterior tibial. The only thing potentially is that add-on code 75774. And again, I've explained why that's a gray area for the add-on code 75774. And then as far as the ultrasound guidance is concerned for the procedure, the findings say that the right groin demonstrates a patent right common femoral artery. But when I go back up to the beginning of the report, you'll notice I didn't mark that with a 76937 because I don't know that there was an image stored. So even though the American College of Radiology says that the report does not have to mention permanent image stored, I need to know that there is a permanent image stored. So I personally say put it in the report. Again, you want to look at your reports through the lens of a third-party payer, because you don't want to have to, get denied. Let's say they ask for documentation before they pay a claim. You don't want a denial, and you don't want a post-payment review where they're asking for money back. So you always want to have all of the documentation in the report whenever possible. So I didn't feel, because I don't know, maybe this particular, provider, they always have a permanent image stored and they feel comfortable coding the 76937 based on that when the other criteria is met. But again, on the payer side, that's how I'm looking at it. So the codes that I came up with for this were the moderate sedation codes. Again, diagnostic imaging, the 75710, that one, checkbox. There, again, I talked about, I want to see better documentation for medical necessity because the CTA was only one day before. And then we have our codes for our interventions with complex lesions with the questionable add-on code there. Okay. So don't you love this real world stuff? There's so many considerations. Coding is definitely not black and white, and sometimes we have to make some judgment calls on what we are doing. Okay, so now I'm going to look at case number 2, and what we have here is a mapping procedure that is occurring. So we are going to walk through this. So we're going to have catheterization codes and we're going to have imaging codes. And the question that came in particularly on this case was about the catheterization codes that should be assigned. So that was the reason why this case was sent in. So like I always like to do, if I have a procedure list at the beginning of the report, I like to look through it and get a feel for what we're doing. So I see, okay, I see arteriograms, the MAA infusion, left hepatic arteriogram. Then I see this 3D CT reconstruction noted here, angiogram post-embolization, femoral arteriogram, closure device placement. Okay, so this looks like based on the procedure list, we've got a mapping procedure, and then we do have a mention of post-embolization angiogram. So that's something that we're gonna want to look out for in our report. So when we jump down into the details of the report, we see that the ultrasound vascular access was utilized for this particular procedure. So that is going to be code 76937. We have those components that are required for documentation. And so access starts at that left common femoral artery. And then from the left common femoral, the catheter goes into the superior mesenteric artery, which is going to be that first order vessel off of the aorta. So that's a 36245. A mesenteric arteriogram was performed. So that's going to be 75726. After that occurs, then the catheter was placed in the celiac for a celiac arteriogram. Now, the celiac is a separate vascular family, and the celiac is the first order vessel coming off of the aorta. So that is a 36245, a first order vessel, but the catheter is going to keep moving in that vascular family. So that catheterization is going to be bundled. Because there's an arteriogram of the celiac, that is reported with 75726. So 75726 can be reported one time per vascular family. You only use the add-on code within the same vascular family. So we have 75726 for the SMA because it's a separate vascular family, 75726 celiac. Then from there, the catheter is moving out of the celiac into that common hepatic artery. So now we're moving into the common hepatic, which is the second order. So that bundles the first order catheterization, and then imaging is performed there. So at that point, we have 36246, and then we have 75774 for the imaging. When we go down to the second paragraph here, the catheter is going to be advanced further, more selectively from the common hepatic into the right hepatic artery where an arteriogram was performed. And so at this point, the 36246 becomes the 36247 because now we're in a third order vessel in that right hepatic artery. Imaging was performed there. So again, we're going to use our add-on code 75774. Then from there, the catheter goes into the anterior segment, right hepatic artery, and an arteriogram is performed. So now the catheter is going more selectively. It's still on the same path, and it goes into the anterior segment. So that's still going to be considered third order. The catheter is just moved further. So we're going to assign 36247 for the anterior segment, right hepatic artery. And then an arteriogram is performed, 75774. I'll address the CT DSA imaging in a few minutes. So we have our 36247, our 75774. Then from there, the catheter goes into the posterior segment, right hepatic artery, and an arteriogram is performed. So that means the catheter had to be pulled back to then go into the posterior segment. It was in the anterior segment. So now it's in the posterior segment. So now we have a second, third order branch. So that is going to become a 36248 for the catheterization code. And then from there, we see that MAA was injected. If you're the facility performing the procedure, you of course can bill for the supply. Then after that, the catheter goes into the left hepatic artery, and then a left hepatic arteriogram was obtained. So the catheter comes all the way out of the right hepatic and then goes into the left hepatic. So now there's the pullback, and now we're in the left hepatic when all that other catheter work was done in the right hepatic. So the right hepatic branches are 36247, 36248. Then when that catheter comes back over to the left hepatic, now the left hepatic is going to be a 36248 as well, okay? Because we're in the same vascular family. It's an additional separate branch in the same vascular family. So for our cap codes, we get the 4 cap codes we have for the case are 36247, 36248 times 2, and then remember the superior mesenteric artery, 36245, that's going to need a 59 on there. It's going to need an XU on there because that's a separate vascular family, and we don't want that to be bundled. And then you see that I did assign the 75774 for the additional imaging that occurred. So we have 1, 2, 3, 4, 5 75774s, and then we have 2 of the 75726s, which actually one of these is going to end up needing the 59 or XU, whatever modifier you want to use. And then we see the microcatheter was removed, completion hepatic arteriogram was obtained, and then patient tolerated the procedures, and then they went to nuclear medicine for SPECT imaging. So the SPECT imaging is going to be coded based off of that separate report. So interestingly, our procedure list has angiogram post-embolization. Clearly that's an error. We don't have any embolization in the case. So that's all that we had was like mapping in this particular case. So let me go back to that CT DSA imaging. So you'll notice that I didn't put any codes tied to that specifically here in the body of the report. But let's go back to our procedure list here. And on our procedure list, this portion of the procedure is summarized as 3D spin CT reconstruction, including the processing on a separate independent workstation under concurrent supervision. So when you have this in your report, sometimes you'll see reports where actually in the body of the report, it'll mention the CT and it'll mention like the 3D, like both of them in there. And so the question comes up is, should I code for that CT, the 76380 and the 76377, or, how should I handle that? Are they both reported? Well, I personally, again, I've seen some differing opinions on this. If the 3D is there and the 3D language is in the report, then I'm going to choose the 3D code 76377 and not actually report the 76380, which is sometimes reported for that limited CT imaging. So that is actually my opinion on that. Some will say to code both. I personally feel that it's unnecessary to code for both of those. If there was no mention of 3D, then I would default to the 76380 in order to report that CT, because this, again, is a mapping procedure. So this would fall under the diagnostic angiography. So those are all of the codes for this case. So again, we have back from the top, we have our 76377 for that, the 3D CT that's done. We have our documentation for the ultrasound guidance, 76937. And then for our catheter codes, we have our 36245 superior mesenteric. And then we have our 36247 and 36248 for the anterior and posterior branches of the right hepatic. And then we have our 36248 for our left hepatic. And then our imaging, for all the additional imaging, we did the add-on code 75774. And then we had the 75726 two times, once for the superior mesenteric and then once for the celiac. So hopefully those of you who submitted your cases, these explanations helped. I know that I answered well beyond the questions, but I try to go through the cases very thoroughly, just for educational purposes for all of the people who I know will watch this. So again, keep your cases coming in. It may take me a little bit of time to get to some of them, especially if I get a lot all at one time. But as I said, I will go through them and review them in the order that they came in. So if you have some cases that you want me to review in Wildcard Wednesday, please send them. So thank you for tuning in, and I'll be back next week.